Good evening. My name is Patrick Watson, and this is my Kinesiology 353 Care and Prevention of Athletic Injury Critical Assignment. Tonight I'm going to be presenting to you common injuries associated with the sport of wrestling. To give you a little bit of background on myself, I was both a youth and high school wrestler. I was an official with the Northern Nevada Wrestling Officials Association, and I have also been an assistant wrestling coach at Silver Stage High School here in Northern Nevada and a Youth USA wrestling coach. Um, my goals for this presentation are to identify the risk factors associated with the sport of wrestling, to identify the signs and symptoms associated with the most common injuries in wrestling, to have you become familiar with the proper anatomical terminology associated with describing these injuries, examining different causes for these injuries and how to treat and prevent them. And finally, I'm going to present some rehabilitative and preventative exercises. So to begin with, some of the common risk factors that we have. First off, the most common would be the level of experience as seen by the wrestler. Um, Normally, beginning wrestlers don't often know when they are going to be putting themselves into a dangerous situation. Proper coaching and proper officials will know how to help prevent this. However, it is common to see more of the younger, inexperienced wrestlers um, tend to put themselves into more harmful situations. And again, the next would be the next risk factor is going to be the environment of the match. Wrestling is a very fast-paced sport. Normally, these matches last their 2-minute rounds, especially in high school and collegiate wrestling. We're looking at 2-minute rounds, 3 rounds, so a total of 6 minutes that you're competing out there, even though it feels a lot longer than that. Normally, officials and coaches are able to identify and stop potentially harmful situations. However, this doesn't always happen. Uh, Finally, sometimes the only thing that could be is a lack of proper coaching. And if the coach is showing the wrong type of move to do or the wrong way to do the move, this can also lead to harmful situations. The first most common injury that we're going to deal with is cauliflower ear. Here we have a diagram of the outer ear. As you can see, you have the helix, the antihelix, the concha, the tragus, the antitragus, and the lobule. Basically, what we're going to be looking at is the helix and the antihelix, which is both superior to the concha and superficial in this area that is in the antihelix, which is inferior to the helix. This is normally where you are going to see the cauliflower injury at. Signs and symptoms. Here is a great image of one of my most favorite MMA fighters who was also a collegiate wrestler and a high school wrestler, Randy Couture. As you can see in his ear there on the um, where in the helix here and the anti-helix is that whole sort of inflamed or swelled looking area that's actually permanent damage to cauliflower ear. And what that is that's a buildup of the blockage due to the ear, buildup of blood. This is also known as auricular hematoma, and it's traumatic damage to the ear, normally causing, as you can see, a shape of a cauliflower head. Um, Very, very easy to assess and treat. This is a very common injury in wrestling. Obviously, the first mechanism for this would be just blunt force trauma, getting smacked in the side of the head or having your head hit the mat forcefully. The second would be just friction injuries caused by that ear being smashed into the mat and just drug along the mat. It could, repeated times to that, is going to cause damage to this ear. Here we have a picture of the assessment of the ear as it's had the damage done. Again, like I said, assessment for this is extremely easy. Palpate the ear. Obviously, we're looking for point tenderness. Obviously, you can see the swelling and the damage to the ear. Pain scale 1 to 10, 10 being the worst pain they've ever felt. Normally, any good wrestler is going to probably tell you that it's not that high. A lot of wrestlers see this as a badge of honor in the sport. not so much in the case. Treatment is extremely easy. What we would do is we would insert a needle and aspirate out that fluid, and then bandage it up, NSAIDs, and rest. However, if the ear is left untreated within 7 to 10 days, that damage will become permanent, and the only thing would be a surgical operation where they would deglove the ear, remove that damaged cartilage, sew it back all up together, and then of course you're looking at longer wait times and recovery time. Some of the preventative exercises are what I'm going to show next. There's nothing really rehabilitative exercises or preventative. Neck mobility, flexion, extension, lateral flexion, and rotation are the ways that you're going to do this. You're going to want to build up those neck muscles in order to not be able to be batted around. Neck strengthening, you, instead of just doing the neck mobility, you add using some kind of resistance bands, towel, and again you would do the same movement as the neck mobility. And finally, the best thing that any wrestler will tell you is neck bridges. You would do prone and supine positions. We would start out at 30 seconds and then progress to 1 minute after 2 weeks. And the next slide here, I just show some presentations of the different exercises. Feel free to view those at your leisure. Next up, we have prepatellar bursitis. This is an inflammation of the prepatellar bursa on the superficial and anterior to the knee. Here we have the synovial joint of the knee. Basically, as you can see, it is the most anterior part of the knee. You have the patella, you have the femur, you have the tibia, and the fibula. And what we're looking at is right here, anterior and superficial, is the prepatellar bursa. This sac can become inflamed and will grow, swell. Obviously, it'll be causing edema. And obviously, what this would do is, again, point tenderness. We're looking to see what the pain level is. Very easy to see for signs and symptoms. Common causes of these are going to be constantly striking your leg onto the mat. Normally this is done in either double or single leg takedown, and just having that constant strike, again, friction and weight, it's going to be the main factors in the cause of this. Assessment and treatment. Assessment and treatment are very easy. Gait test for the patient. See if they are favoring one leg over the other, and then palpate the knees. Of course, you're going to want to make sure for symmetry for one, but checking for point tenderness and swelling in those legs. Also, if you need to, you don't have to, but an x-ray can be done to look for trauma to any of the bones. Obviously, if we have trauma to the bones, then it's another injury completely. Treatment for this is, again, aspiration of the knee, and then giving of NSAIDs, rice. That would be for mild to moderate. If the injury, again, is severe enough to where it requires surgery, you could be looking at an either arthroscopic or open bursectomy. And with those, the complications that could arise are sepsis and just infection and inflammation of the knee. So some preventative exercises. Again, there's really no rehabilitative exercises for prepatellar bursitis. You're going to want to just kind of prevent this injury, and that's done usually through strengthening of the quadriceps muscles. Here we have, barbell reverse lunge, 3 sets, 10 reps, progression to 15 reps after a week. Next up, we would have a front squat with kettlebells. You could also use a weight plate, or you can use dumbbells. Whatever you have that is available to you would be the best. Finally, one thing that I like to do is front band walk and have the wrestler do this in their stance. This will help strengthen those quadriceps and also teach them muscle memory on what to what to be ready for in a match. Here again is a video presentation of those exercises. Enjoy it. The final injury that we have is medial collateral ligament, or an MCL sprain. There are actually 3 grades to this sprain, and we will go through each one. Here I'm going to show you an anterior view of the knee. Obviously we have our femur, and then we have our lateral and medial epicondyles, the medial collateral ligament over here, then we have the tibial head, and what we're going to be looking at is on this medial side here. It's also superficial. This is probably one of the easiest ligaments to sprain in the leg. Valgus force would be caused for concern on here, and what it will be is usually toroidal force, and just that rotation of the knee, and could cause any kind of sprain or tear. Signs and symptoms: edema. Edema is a huge one. Obviously, we'd be looking for any kind of hematoma. As you can see here, we have hematoma, we have edema, point tenderness again, and then gait. See how your patient walks, and then of course, for more diagnostic tests, X-ray and magnetic resonance imaging, or MRI. Of course, there are, like I said, 3 grades to this sprain. Here we have the grade 1, 2, and 3. Normally, a grade 1 is just a little bit of damage, not a lot. Knee is still stable, but there's inflammation to that MCL. Next, you have a grade 2, which is a partial tear. Again, inflammation and edema are going to be there. Finally, you have a grade 3, which is just a complete tear. Normally, the patient will not be able to walk with this, and any one of these are going to require a brace and immobilization of the knee. Here are just some different slides showing the toroidal forces that are applied and how those can affect the knee. Assessment of this injury is extremely easy. Again, we would do a gait test, physical examination of the patient, and follow that up with any kind of radiological testing, X-ray, MRI, just to determine how bad of a condition we have. Treatment for grade 1 and grade 2 is usually immobilization and placing in a brace, and then physical therapy and RICE. Grade 3 surgery is usually required, and then again follow up with the above physical therapy and RICE. Here are just some different forms of those surgical and non-surgical interventions to it. Next, we have rehabilitative and preventative injuries. With these rehabilitative injuries, our exercises, what we're going to show is static quad contractions for 1, 2 sets, 10 to 15 reps, holding for 3 seconds, 3 times per week. Progression to 15 to 20 after 1 week. Next would be heel slides, 2 sets, 10 reps, 3 times per week, with progression to 3 sets after 1 week. And knee flexion and extension, or standing on one leg, 3 sets of 10 reps, 3 times per week, progressing to 20 reps after 1 week. Again, here is a video showing those different exercises. If you have any questions or concerns, please feel free to contact me at the below listed contact. Thank you and have a good day.